Now, let's talk a little bit about various chemotherapeutic agents commonly used to treat cancer.
Sure, chemotherapeutic agents are drugs used to kill or stop the growth. Alkylating agents work by adding alkyl groups to DNA, which prevents the cancer cells from dividing. Examples include cyclophosphamide and ifosfamide. Next, antimetabolites mimic the building blocks of DNA or RNA, interfering with the cancer cell's ability to grow and multiply. Common examples are methotrexate and 5-fluorouracil. Then you have anthracyclines, which interfere with enzymes involved in DNA replication. A well-known example is doxorubicin. There are also plant alkaloids like the vinca alkaloids, vincristine, vinblastine, which disrupt microtubules and prevent cell division. Finally, there are targeted therapies and newer immunotherapies, but those are often considered separate from traditional chemotherapy. Each type of agent has its own side effects and is chosen based on the specific type of cancer.
Which type of chemotherapeutic agents can cause double strand DNA fractures?
Topoisomerase inhibitors are a type of chemotherapeutic agent that can cause double-strand DNA breaks. They work by interfering with the topoisomerase enzymes that help unwind DNA during replication. When these enzymes are inhibited, it can lead to permanent double-strand breaks in the DNA, which can ultimately kill the cancer cells. A well-known example is etoposide, which targets topoisomerase II. Another example is irinotecan, which inhibits topoisomerase I. These double-strand breaks are highly lethal to rapidly dividing cells.
What is the difference between the function of topoisomerase II and topoisomerase I?
Topoisomerase 1 and 2 both help manage DNA supercoiling and prevent tangling during replication. Topoisomerase 1 makes a single-strand cut in the DNA to relieve excessive twisting or supercoiling. After the tension is reduced, the enzyme reseals the strand. Topoisomerase 2, on the other hand, makes temporary double-strand cuts to untangle DNA. This is necessary for separating intertwined DNA strands, especially during cell division. Because topoisomerase 2 acts on both strands of the DNA, its inhibition is more likely to lead to double-strand breaks. That's why topoisomerase 2 inhibitors, like etoposide, are associated with more DNA damage than topoisomerase 1 inhibitors.
What is the difference between positive supercoiling and negative supercoiling?
Positive and negative supercoiling are ways DNA twists in response to strain. Positive supercoiling occurs when the DNA helix is twisted in the same direction as its natural right-handed spiral, making it more tightly wound. This often happens ahead of replication forks, or transcription machinery, and can make it harder for the strands to separate. Negative supercoiling is when the DNA is twisted in the opposite direction of the natural spiral, loosening the helix. This makes it easier to separate the strands, which helps with processes like transcription and replication. Cells maintain a balance of both types to ensure DNA is accessible but not overly strained. Topoisomerases help relieve either type of supercoiling, depending on the needs of the cell.
Which type of topoisomerase can deal with positive supercoiling and why?
Topoisomerase 1 is primarily responsible for dealing with positive supercoiling. It does this by making a temporary single-strand cut in the DNA helix, which allows the DNA to unwind and release the tension created by positive supercoiling. This function is important because when processes like replication or transcription move along DNA, they cause overwinding ahead of them, creating positive supercoils. Topoisomerase 1 helps relax these coils so that the cellular machinery can keep moving smoothly.
What is the mechanism of action of podophyllin and what is its clinical use?
Podophyllin is a plant-derived resin that works by inhibiting topoisomerase 2. This inhibition leads to DNA damage by preventing the unwinding and religation of DNA, which results in cell cycle arrest and cell death, especially in rapidly dividing cells. Clinically, podophyllin is commonly used for the topical treatment of genital warts caused by the human papillomavirus HPV. It's applied directly to the warts to stop their growth by killing the affected cells. However, because it's quite potent and can also affect normal tissues, care must be taken to apply it only to the lesion.
So, is it correct to say that topoisomerase 1 drugs, like irinotecan, can only relieve negative supercoiling, while topoisomerase 2 drugs, like podophyllin and etoposide, can relieve both positive and negative supercoiling? What is the mechanism behind this?
Excellent question, and your thinking is quite close to the mechanistic truth, though we need to clarify and nuance the roles of topoisomerase 1 versus topoisomerase 2 enzymes and their corresponding inhibitors, like irinotecan and etoposide, in supercoiling dynamics. DNA supercoiling basics. Positive supercoiling, overwinding of DNA ahead of replication forks or transcription machinery. Negative supercoiling, underwinding of DNA behind the machinery, facilitates strand separation. Topoisomerase function overview. Feature, topoisomerase 2. Mechanism. Mechanism cuts one strand, cuts both strands. ATP required, supercoils relaxed, both positive and negative. Both positive and negative action. Relieves torsional strain by allowing rotation of one strand around the other. Passes an intact double helix through the break before religating. Clinical drugs, irinotecan, topotecan, etoposide, doxorubicin, podophyllitoxin. Important clarification. Both Topo I and Topo II can relieve both positive and negative supercoils. The difference lies in mechanism and DNA context, single versus double strand break. So your assumption that Topo I only relieves negative supercoiling is not accurate. It relieves both, just less efficiently when there is very high torsional stress or complex topologies. Mechanism of supercoil relaxation. Topoisomerase on nicks one strand of the DNA, allows controlled rotation of the intact strand around the broken strand. No ATP required, relieves torsional strain using the energy from the supercoil itself. Slower with very high supercoiling or topologically complex structures, e.g. catenanes. Topoisomerase 2 cuts both DNA strands, passes another segment of DNA through the break, decatenation unknotting, ATP dependent, required for chromosome condensation, segregation, and untangling knots. More potent for resolving overwound regions and DNA entanglements. Anti-cancer drugs, drug, inhibits mechanism. Irinotecan, topotecan, Topo I, stabilize the NICT complex, prevent religation, DNA damage during replication. Etoposide, doxorubicin, Topo II, stabilize double-strand breaks, replication forks collapse, apoptosis. Why this matters in cancer. Cancer cells divide rapidly, generate positive supercoiling ahead of replication forks. Topo I inhibitors block relaxation of torsion, replication stress. Topo II inhibitors cause irreversible double-strand breaks, DNA damage checkpoints, apoptosis. References, Wang J.C.
What is the mechanism of action of doxorubicin, which is an anthracycline?
Doxorubicin works primarily by intercalating into DNA. This disrupts the function of topoisomerase 2, an enzyme crucial for DNA replication and transcription. By preventing the religation of the DNA strands, it leads to DNA damage and ultimately triggers cell death, especially in rapidly dividing cancer cells. Additionally, doxorubicin generates free radicals that contribute to its cytotoxic effects.
So, what environmental factors can cause double strand DNA breaks, and why is it important?
Environmental factors like ionizing radiation, such as X-rays or gamma rays, and certain chemicals like chemotherapeutic agents or industrial pollutants can cause double-strand DNA breaks. These breaks are significant because they can disrupt the genetic code and lead to mutations if not properly repaired. That can contribute to cancer or cell death. Proper DNA repair is essential to maintain genomic stability and prevent disease.
Why is it harder for cells to repair a double stranded DNA break than a single stranded break?
It's harder for cells to repair a double strand break because both strands of the DNA helix are severed. That means there's no intact template strand to guide accurate repair. With only a single strand break, the cell can often use the opposing strand as a template to fix the damage. But with a double strand break, the cell has to rely on more error-prone processes like non-homologous end joining or more complex homologous recombination. Errors in this repair can lead to mutations, chromosomal abnormalities, or cell death, which is why double strand breaks are more dangerous and harder to fix.
So we know that ionizing radiations and some industrial pollutants, and also some oxidizing agents can cause double-stranded DNA breaks. How about chemotherapeutic agents? What chemotherapeutic agents can cause double-stranded DNA breaks?
Several chemotherapeutic agents can cause double-strand DNA breaks. These include drugs like doxorubicin and other anthracyclines, as well as etoposide and topotecan, which inhibit topoisomerase II. These drugs disrupt DNA replication and lead to breaks in both strands. Additionally, drugs like cisplatin or carboplatin can cause crosslinks that indirectly lead to double-strand breaks during repair attempts. These mechanisms help kill rapidly dividing cancer cells, but can also damage healthy cells.
How about alkylating agents such as cyclophosphamide? Does it also cause double-stranded DNA breaks?
Yes, alkylating agents like cyclophosphamide can also cause double-strand DNA breaks. These agents add alkyl groups to DNA, leading to crosslinks between DNA strands or between DNA and proteins. When the cell tries to repair these crosslinks, it can result in double-strand breaks. That's one of the ways these drugs kill cancer cells, but also why they can be toxic to normal cells.
Can you name the most commonly used alkylating agents in treatment of cancer?
Sure, some of the most commonly used alkylating agents for cancer treatment include cyclophosphamide, ifosfamide, chlorambucil, melphalan, and busulfan. These drugs are widely used because they're effective at damaging cancer cell DNA and preventing their replication and growth.
What group of antineoplastic agents does cisplatin and carboplatin belong to?
Cisplatin and carboplatin belong to a group of antineoplastic agents called platinum-based compounds or platinum analogs. These drugs form DNA crosslinks that lead to disruption of DNA function, ultimately causing cell death. They're often used to treat various types of cancers, including testicular, ovarian, and lung cancers.
Which groups of anti-cancer medications cause microtubular dysfunction and thus cause dysfunction in separating chromosomal strands during mitosis?
The group of anti-cancer medications that cause microtubular dysfunction are called mitotic inhibitors. They include two main classes, the vinca alkaloids, like vincristine and vinblastine, which prevent microtubule formation, and the taxanes like paclitaxel and docetaxel, which stabilize microtubules and prevent their disassembly. Both mechanisms disrupt the normal process of mitosis, preventing cancer cells from dividing properly.
Is it correct to assume that antineoplastic medications that act only during mitosis or only during new DNA synthesis are less toxic to non tumoral cells than antineoplastic agents that can cause double stranded DNA breaks, like alkylating agents or platinum based compounds?
Yes, your assumption is generally correct, and it's an important principle in the therapeutic index and toxicity profile of anti-cancer drugs. Let's break it down based on cell cycle specificity, mechanism of action, and off-target toxicity. Hack 1. Cell cycle specificity of antineoplastic agents. Drug class. Cell cycle phase. Examples. Antimetan synthesate cytarabine. Mitotic inhibitors, M phase, inhibit spindle formation, block mitosis, vincristine, paclitaxel. Anti-metabolites phase, inhibit DNA synthesis or repair, 5-FU, methotrexate, cytarabine. Topoisomerase inhibitors, S and G2M phase, cause strand breaks during replication, irinotecan, etoposide. Alkylating agents, cell cycle nonspecific, cause crosslinks, DSPs, apoptosis. Cyclophosphamide, busulfan, platinum-based compounds, cell cycle nonspecific, DNA crosslinking, DSPs, cisplatin, carboplatin, anthracyclines, e.g. doxorubicin, broad intercalations free radical formation, topo-2 inhibition, doxorubicin. 2. Why mitotic and S-phase specific drugs tend to be less toxic. These drugs primarily target cells that are actively dividing, which is more common in tumor cells than in most adult tissues. They spare quiescent GSIP or slowly dividing cells, such as neurons or resting hepatocytes. Therefore, their toxicity is more confined to rapidly dividing normal cells, e.g. bone marrow, GI epithelium, hair follicles, and less systemic. Hammer 3. Why alkylating agents and platinum compounds are more toxic. These are non-cell cycle specific agents. They can damage DNA at any phase, including in non-dividing cells. They cause double-stranded DNA breaks, or cross-linking, which leads to apoptosis in tumor cells, long-term damage to normal cells, higher risk of secondary malignancies, infertility, and organ toxicity. Example, cyclophosphamide can cause hemorrhagic cystitis, myelosuppression, and secondary lupus.
So, mitosis or S-phase specific drugs like antimetabolites and microtubule inhibitors tend to be less systematically toxic to non-dividing normal cells. But in contrast, cell cycle non-specific agents such as alkylating agents, platinum-based drugs, and anthracyclines pose a higher risk of systemic and long-term toxicity, including DNA damage in non-tumor cells. The least dangerous of all these are mitotic inhibitors. We have vinca alkaloids and taxanes as mitotic inhibitors. These act primarily on the M phase of the cell cycle, therefore inhibit mitotic spindle function by interfering with microtubule formation or microtubule function, and thus they inhibit mitosis in rapidly dividing cells. So they have low risk of secondary malignancies, and they are also not toxic to non-dividing cells. Then we have antimetabolites such as 5-FU, cytarabine, methotrexate. These act in the S phase and inhibit DNA synthesis or repair. Antimetabolites are generally not toxic to non-dividing cells as well, but they have some moderate risk of secondary malignancy, but not as high as alkylating agents or platinum drugs or anthracyclines. After these, we have topoisomerase inhibitors. The topoisomerase inhibitors act in the S phase and also the G2 and M phase of the cell cycle, and they cause DNA breaks during replication. So topoisomerase inhibitors have more risk of secondary malignancy than, say, mitotic inhibitors or antimetabolites, but not as high as alkylating agents and platinum drugs. Topoisomerase inhibitors can be toxic to non-dividing cells because topoisomerase II activity is important even in quiescent cells. Then we have the anthracyclines, such as doxorubicin, which are cell cycle nonspecific. They intercalate themselves into the DNA and inhibit topoisomerase 2 and also promote free radical formation. These agents are toxic to non-dividing cells as well as to cancer cells, but their risk of secondary malignancy is about moderate, not as high as alkylating agents and platinum drugs. Anthracyclines are also well known for their cardiotoxicity. And at last, we have the most dangerous drugs, which are alkylating agents and platinum drugs. Both of these are cell cycle nonspecific. Both cause DNA crosslinks and double-strand DNA breaks and lead to cell apoptosis. Alkylating agents like cyclophosphamide or busulfan and platinum-based compounds like cisplatin and carboplatin. These have high risk of secondary malignancies and are also way toxic to non-dividing cells as well as rapidly dividing cells. So let's talk about the cellular growth cycle, which consists of four distinct phases: G1, S phase, G2 phase, and then the mitosis or M phase.
Exactly. Those are the main phases of the cell cycle. Let's break them down quickly. First, the G1 phase is where the cell grows and performs its normal functions. Next, the S phase is when DNA is replicated. After that comes the G2 phase, where the cell continues to grow and prepares for mitosis. Finally, the M phase, or mitosis, is where the cell divides into two daughter cells. After mitosis, the cycle starts over again.
So progression through these phases is controlled by checkpoints. Checkpoints are surveillance systems that interrupt the cell cycle or can potentially induce apoptosis if cells do not meet the requirements to progress forward.
Exactly. These checkpoints are crucial for maintaining the integrity of the cell. There's a main checkpoint at the end of G1, often called the restriction point. If conditions aren't right, like if DNA is damaged, the cell will pause and try to repair the issue. If it can't be fixed, the cell may undergo apoptosis or programmed cell death to prevent damaged cells from dividing. There are also checkpoints during G2 and M phases to ensure everything is in order before the cell divides.
So the transition from G1 to S phase, that is the initiation of DNA replication, requires for cells to meet certain requirements. For example, the cell size and nutrient status should be optimal for the initiation of DNA replication. The cell should have received appropriate growth factor signals, and proper surveillance and repair of damaged DNA should have been done.
Absolutely right. The G1 checkpoint essentially ensures that all conditions are favorable before the cell commits to DNA replication in the S phase. If the cell size is too small, nutrients are lacking, or growth signals are absent, the cell won't move forward. Plus, if there's any DNA damage, the cell waits until repairs are complete before proceeding. It's like a safety mechanism to ensure everything is in good shape before replication starts.
Which conditions are checked at the G2 to M transition phase?
At the G2 to M transition, the cell primarily checks for three major conditions. First, it assesses whether all the DNA has been completely replicated. Second, it checks for DNA damage and makes sure any damage has been repaired. Finally, The cell also verifies that it has enough resources, like energy, to move into mitosis. If any of these conditions aren't met, the cell will pause at this checkpoint until everything is corrected. This ensures that only healthy cells proceed into division.
There is an additional checkpoint called the spindle checkpoint. What is this checkpoint's function?
The spindle checkpoint ensures that all chromosomes are properly attached to the spindle fibers before the cell proceeds with division. This checkpoint happens during mitosis, specifically at metaphase. If chromosomes aren't correctly aligned or attached, the cell will halt the process until everything is in order. This helps prevent missegregation of chromosomes, which could lead to serious genetic errors in the daughter cells.
So, what are the most important control mechanisms for the G1 to S phase transition?
The G1 to S transition is controlled mainly by cyclins and cyclin-dependent kinases, or CDKs. Specifically, cyclin D and cyclin E, along with their corresponding CDKs, play key roles. These molecules monitor external signals, like growth factors, and internal conditions, like DNA integrity and nutrient availability. If everything checks out, the cyclin CDK complexes trigger the transcription of genes required for DNA replication. If conditions aren't right, inhibitors can block these complexes from pushing the cell into the S phase.
So, when cyclin D attaches itself to the CDK4/6 complex, what happens?
When cyclin D binds to CDK4 or CDK6, the complex becomes active and starts phosphorylating target proteins. One key target is the retinoblastoma protein, also called RB. Phosphorylation of RB releases a transcription factor called E2F, which then activates genes needed for DNA replication. So this complex acts like a green light, allowing the cell to move past the G1 checkpoint and head towards the S phase.
So, unless the retinoblastoma gene, the retinoblastoma protein is phosphorylated, it inhibits the cell moving forward from the G1 to S phase.
Exactly. When the retinoblastoma protein isn't phosphorylated, it tightly binds to E2F and keeps it inactive. That stops the transcription of genes required for DNA replication, so the cell is effectively blocked from moving into the S phase. Only when RB is phosphorylated by the cyclin CDK complex can the cell progress forward.
So, in cells in the body which they don't intend to divide, the retinoblastoma protein is firmly attached to the E2F, and this inhibits the cell from going from G1 to S phase.
Exactly. In non-dividing or quiescent cells, the retinoblastoma protein remains bound to E2F, keeping those genes switched off. That prevents the cell from moving into the S phase and initiating DNA replication. This is how certain cells maintain a resting state and only divide when they receive appropriate signals.
So, what is the connection between the retinoblastoma protein's function and P53?
The P53 protein is like the cell's quality control manager. If there's DNA damage or stress, P53 becomes active and can either pause the cell cycle to allow repairs or trigger apoptosis if the damage is too severe. P53 also influences the retinoblastoma protein. If P53 detects problems, it can promote the production of proteins that keep retinoblastoma in its active unphosphorylated form, preventing the cell from progressing to the S phase. So together, P53 and the retinoblastoma protein act as safeguards, making sure the cell only divides when it's healthy.
And how does the P53 protein detect if there is any DNA damage?
P53 detects DNA damage through a network of sensor proteins. When DNA damage occurs, specialized proteins like ATM and ATR become activated. These proteins detect abnormalities in the DNA structure and signal P53 by adding phosphate groups to it, which stabilizes and activates P53. Once activated, P53 can then regulate the transcription of genes that halt the cell cycle or initiate DNA repair processes. If the damage is too severe, p53 can push the cell towards apoptosis to prevent the propagation of damaged DNA.
So, growth factors, like for example, epidermal growth factor, have receptors which are of the tyrosine kinase receptor type, and they induce phosphorylations in proteins inside the cell. How does these phosphorylations convey the message of the growth factor to the cyclins?
Great question. When a growth factor, like epidermal growth factor, binds to its receptor, that receptor's tyrosine kinase activity gets activated. This leads to a cascade of phosphorylation events inside the cell. These phosphorylation signals activate a series of signaling pathways, the most important of which is the MAP kinase pathway. This eventually leads to the activation of transcription factors that increase the production of cyclins, particularly cyclin D. As cyclin D levels rise, it binds to CDK4 or CDK6, pushing the cell past the G1 checkpoint. So this chain of events is how an external growth factor signal ends up encouraging the cell to grow and divide.
So, what is the function of the genes such as BAX and BAD in cellular cell cycle control?
AX and BAD are pro-apoptotic genes, meaning they promote cell death when necessary. They are part of the cell's fail-safe system during the cell cycle and are closely linked to p53 activity. If the cell detects irreparable DNA damage or other stress, p53 can trigger the expression of BAX and BAD. These proteins then promote mitochondrial changes that lead to apoptosis or programmed cell death. In essence, BAX and BAD ensure that if a cell is damaged or functioning abnormally, it doesn't continue dividing. This helps prevent the development of cancer or other diseases caused by uncontrolled cell growth.
And what are the functions of the BCL genes, such as BCL2 and BCL6?
BCL genes, like BCL2 and BCL6, they are anti-apoptotic, meaning they help the cell survive and avoid programmed death. BCL2, for example, prevents apoptosis by blocking the activity of pro-apoptotic proteins like BAX. It does this by stabilizing the mitochondrial membrane, preventing the release of factors that would trigger cell death. On the other hand, BCL6 is a transcriptional regulator that can suppress certain genes involved in the cell cycle and immune responses. It's more involved in controlling cell growth and differentiation, particularly in immune cells like B cells. So together, while BAX and BAD push the cell towards death if things go wrong, BCL2 and BCL6 help the cell stay alive and function properly under normal conditions.
So, can you name some chromosomal translocations involving BCL genes that make them oncogenes in certain lymphatic tissue malignant?
Sure, one well-known example is the T14:18 translocation. It involves the BCL2 gene on chromosome 18 and the immunoglobulin heavy chain gene on chromosome 14. This translocation causes overexpression of BCL2, preventing apoptosis and allowing the lymphoma cells to survive longer than they should. Another example is the T3:14 translocation, which involves BCL6 and the immunoglobulin heavy chain gene. This translocation leads to dysregulated expression of BCL6, contributing to certain types of B-cell lymphomas. These translocations turn the BCL genes into oncogenes, promoting cancer development by allowing cells to avoid normal apoptosis signals.
So, we know that many cancers exploit the checkpoint from G1 to S phase and achieve unregulated cellular growth via this mechanism.
You're right. Many cancers exploit checkpoints that normally regulate the cell cycle. The G1 to S transition is crucial because it's where the cell commits to DNA replication. If this checkpoint is bypassed or deregulated, cells can divide uncontrollably. This unchecked growth is a hallmark of cancer. Often mutations in tumor suppressor genes like p53 or in growth-promoting oncogenes disrupt the control mechanisms that would normally halt abnormal growth.
So, can you name an antineoplastic agent that actually has cycle in its name and is a checkpoint inhibitor?
Yes, the drug you're referring to is likely palbociclib. It's a CDK4/6 inhibitor, and the cyclib in its name comes from cyclin-dependent kinases. These kinases regulate the G1 to S phase transition. By inhibiting these kinases, palbociclib effectively stops cancer cells from passing that checkpoint, slowing down their division. It's commonly used in certain types of breast cancer.
So, if we inhibit the CDK4/6, they can't bind to cyclin D, and then the resulting complex does not form, which can inactivate the retinoblastoma tumor suppressor protein. So the retinoblastoma protein remains active, and it attaches itself firmly to E2F and therefore does not allow the cell to go from G1 to S.
Exactly. That's the key mechanism. The active retinoblastoma protein, or RB, suppresses transcription factors like E2F, which are crucial for initiating DNA replication. When CDK4/6 are inhibited, RB stays active, and E2F remains bound and inactive. As a result, the cell can't move from the G1 phase to the S phase, preventing further division. That's how these types of drugs slow down tumor growth.
So CDK inhibitors such as palbociclib are another group of antineoplastic agents who are only active in rapidly dividing cells, and they do not cause any damage or harm to quiescent cells in G0 or in G1 who do not divide as rapid.
Right. That's a big advantage of CDK inhibitors. They're more targeted to rapidly dividing cells, like cancer cells, because those cells are actively cycling through G1 to S. Quiescent cells in G0, or those not dividing rapidly, are less affected, which helps reduce harm to normal tissues. That's why they're often better tolerated in some cases.
So the main adverse reactions associated with CDK4/6 inhibitors, such as palbociclib, is bone marrow suppression.
Exactly. One of the main side effects of CDK4.
Let's talk about the folic acid metabolic pathway. We know that folic acid is reduced to dihydrofolate and then again to tetrahydrofolate by the enzyme DHF reductase.
Exactly. Dihydrofolate reductase, or DHFR, catalyzes those reduction steps. After folic acid is converted first to dihydrofolate, it's then reduced again to tetrahydrofolate, which is the active form. This active tetrahydrofolate is crucial for transferring 1 carbon units in various metabolic processes, like DNA synthesis.
In folic acid metabolism, folic acid is first converted to dihydrofolate and then again to tetrahydrofolate by the enzyme DHF reductase. The tetrahydrofolate is the active form and has multiple forms of 1 carbon donors which can donate 1 carbon molecules to various biosynthetic processes inside cells.
Exactly. Tetrahydrofolate plays a crucial role in transferring these 1 carbon units. These transfers are essential for synthesizing nucleotides, which are the building blocks of DNA and RNA, and also for the metabolism of certain amino acids. Without it, many fundamental cellular processes would be disrupted.
So the 1 carbon donors can be, and the 1 carbon units that are donated can be in the form of formyl tetrahydrofolate, methylene tetrahydrofolate, methyl tetrahydrofolate, and so on and so forth.
Exactly. These different forms of tetrahydrofolate carry 1 carbon units at different oxidation states. They are used in various biochemical reactions, including purine and thymidylate synthesis, as well as amino acid metabolism. Each form is tailored to specific reactions within the cell.
So, which form is associated with which specific reaction?
Sure, let me break that down. 4-mil tetrahydrofolate is mainly involved in purine synthesis, which is essential for DNA and RNA. Methylene tetrahydrofolate is crucial for thymidylate synthesis, which is needed for making thymine, a DNA building block. Methyl tetrahydrofolate is important in transferring a methyl group for the conversion of homocysteine to methionine, a critical amino acid reaction. Each form of tetrahydrofolate provides the appropriate 1 carbon unit needed for these specific biosynthetic processes.
Now, so N5 and N10 methylene tetrahydrofolate is the active compound that is needed for thymidylate synthetase to synthesize thymidine from uracil.
Exactly. N5-N10 methylene tetrahydrofolate donates a 1 carbon unit to convert DUMP, deoxyuridine monophosphate, into DTMP, deoxythymidine monophosphate, which is an essential precursor for DNA synthesis. That reaction is catalyzed by thymidylate synthase, and it's critical for proper DNA replication and repair. Without this process, cells can't produce DNA properly.
When methylene tetrahydrofolate donates its methylene group to DUMP to produce DTMP, it is converted back to dihydrofolate, and it needs dihydrofolate reductase to be converted back to its active form again.
Exactly. After donating the methylene group, tetrahydrofolate is converted back to dihydrofolate. Then dihydrofolate reductase, DHFR, recycles it back to tetrahydrofolate, maintaining the cycle. That's why DHFR is so important for folate metabolism and DNA synthesis.
Now, methotrexate inhibits dihydrofolate reductase. What other drugs do you know that inhibit DHF reductase?
Drugs that inhibit dihydrofolate reductase.
Which other drugs do you know that inhibit dihydrofolate reductase?
Besides methotrexate, other well-known drugs that inhibit dihydrofolate reductase include trimethoprim, which is often used as an antibiotic, and pyrimethamine, which is used in treating malaria and toxoplasmosis. Cycloguanil is another example, especially in anti-malarial treatments. These drugs all target the enzyme and disrupt folate metabolism in different ways, depending on the organism they're targeting.
So, pyrimethamine inhibits bacterial dihydrofolate reductase.
Exactly. Pyrimethamine primarily targets the dihydrofolate reductase enzyme in parasites like the malaria parasite. It's very effective in interfering with folate metabolism in those organisms, which helps to stop their growth and replication. That's why it's a common drug for treating malaria and toxoplasmosis.
So does the anticonvulsant phenytoin also inhibit dihydrofolate reductase?
Yes, phenytoin, which is primarily an anticonvulsant, can also inhibit dihydrofolate reductase to a certain extent. This effect can contribute to folate deficiency in some individuals taking the drug long-term. However, this is a secondary effect compared to its primary role in controlling seizures.
So what are the clinical correlations for phenytoin being able to block DHF reductase?
When phenytoin inhibits dihydrofolate reductase, it can reduce the levels of active folate in the body over time. This can lead to folate deficiency, which is clinically significant because it can cause megaloblastic anemia or other blood cell abnormalities. In pregnant women, long-term use of phenytoin can also increase the risk of neural tube defects due to lower folate levels. That's why folate supplementation is often recommended for patients on long-term phenytoin therapy.
Are there any other anticonvulsants that can block the effects of DHA reductase?
Yes, besides phenytoin, lamotrigine is another anticonvulsant that can weakly inhibit dihydrofolate reductase. However, its inhibition effect is weaker than other antifolates like methotrexate or phenytoin. So while it can contribute to folate reduction in the body, it's not as strong in that regard as some other drugs. Still, this can be clinically important over long-term use, particularly for patients at risk of folate deficiency.
What anticonvulsants, when the patient is taking them for long term, do need folic acid supplementation along their use?
Several anticonvulsants can lower folate levels, especially those that induce liver enzymes. The main drugs are phenytoin, carbamazepine, phenobarbital, and primidone. These are enzyme-inducing drugs that can significantly reduce folate levels over long-term use. Because of this, folic acid supplementation is often recommended to prevent deficiency. This is especially important for women of childbearing age, as low folate can increase the risk of neural tube defects during pregnancy. So patients on these medications long-term often need folic acid supplementation.
So, we know that leucovorin or folinic acid, which is N5,4-mil tetrahydrofolate, can rescue cells from the toxic effects of methotrexate.
Exactly. Leucovorin, or folinic acid, provides a bypass for the blocked dihydrofolate reductase pathway when methotrexate inhibits it. It directly supplies the active form of folate that cells need for DNA and RNA synthesis, helping rescue normal cells from methotrexate's toxic effects. That's why it's often used in leucovorin rescue therapy after high-dose methotrexate treatment to minimize harmful side effects.
So how is it that folinic acid can rescue normal cells from the toxic effects of methotrexate, but rapidly dividing cells such as immune cells or tumoral cells are not rescued from this effect by the supplementation with folinic acid?
That's a great question. The key difference is that normal cells typically absorb folinic acid more efficiently than tumor cells or rapidly dividing immune cells. This difference in uptake happens because cancer cells often rely more heavily on de novo folate synthesis pathways, which methotrexate blocks. Leucovorin bypasses that block directly by providing the active folate that healthy cells can utilize more rapidly. Tumor cells, due to their altered metabolism and high proliferation rate, are less efficient at using the provided folinic acid. As a result, healthy tissues are rescued while the tumor cells remain vulnerable to methotrexate's toxic effects. That selective rescue mechanism is what makes leucovorin so effective in protecting healthy cells.
So, what considerations should we have regarding the timing of administration of folinic acid?
Timing is crucial when administering folinic acid after methotrexate. If you give it too early, it might rescue the tumor cells as well as the normal cells. The goal is to allow methotrexate enough time to damage the rapidly dividing cells before rescuing the healthy cells. Typically, folinic acid is administered about 24 to 48 hours after methotrexate to strike that balance. That way, methotrexate has enough time to affect cancer cells, but healthy cells are still protected from long-term toxicity. The timing may vary based on the methotrexate dose and the individual patient's metabolism, but that's the general guideline.
So, what is the effects of folinic acid supplementation on 5-FU?
Folinic acid is often used alongside 5-fluorouracil, 5-FU, to enhance its effectiveness. This combination is commonly used in cancer chemotherapy, especially for colorectal cancer. Folinic acid stabilizes the bond between 5-FU and the enzyme thymidylate synthase, which increases 5-FU's ability to inhibit DNA synthesis in rapidly dividing cells. Essentially, folinic acid boosts the anti-cancer effects of 5-FU by helping it bind more tightly and for longer, making the chemotherapy more effective.
Can you briefly describe the mechanism of action of 5-fluorouracil?
Sure. 5-fluorouracil, or 5-FU, is a chemotherapy drug that works by inhibiting thymidylate synthase, an enzyme necessary for DNA synthesis. Once inside cells, 5-FU is converted into active metabolites, one of which directly binds to thymidylate synthase. This blocks the production of thymidine, a building block of DNA. Without thymidine, rapidly dividing cells, like cancer cells, can't properly replicate their DNA and eventually die. That's how it exerts its anti-cancer effects.
Nucleoside analogs are a major class of antineoplastic, anti-cancer agents that mimic natural nucleosides and interfere with DNA or RNA synthesis, primarily targeting rapidly dividing cells such as cancer cells. They are used in treating hematologic malignancies, some solid tumors, and certain viral infections. Here's an evidence-based overview of the main nucleoside analog anti-cancer drugs, grouped by their structure, mechanism, and key clinical. 1. DNA chain termination and polymerase inhibition. Cytarabine, gemcitabine, fludarabine, cladribine incorporate into DNA during S phase, lead to premature chain termination and inhibition of DNA polymerase. Some also inhibit ribonucleotide reductase, DNTPs for DNA synthesis. 2. Thymidylate synthase inhibition. 5-FU capecitabine inhibit thymidylate synthase, DTMP, DNA damage and cell death. 5-FU also incorporates into RNA, impairing RNA processing. 3. Epigenetic modifiers, azacitidine, decitabine, inhibit shard DNA methyltransferases, cause hypomethylation of DNA, reactivation of tumor suppressor genes. Particularly useful in myelodysplastic syndromes, MD. Most nucleoside analogs are S-phase specific. Their efficacy is closely related to intracellular phosphorylation by kinases to active triphosphate forms. Resistance can arise from increased drug inactivation, reduced kinase activity, or upregulated DNA repair mechanisms. Toxicities often include myelosuppression, mucositis, neurotoxicity, e.g. cytarabine cerebellar syndrome, and GI symptoms.
Fludarabine and cladribine are more used in CLL and low-grade lymphoma, but cytarabine is primarily used in leukemias with high turnover. What is the difference in the mechanism of action of these drugs that leads to such a distinction?
An insightful question. This digs into the pharmacodynamics, cell cycle specificity, and molecular mechanisms that distinguish cytarabine, fludarabine, cladribine, and gemcitabine, especially in relation to their effectiveness in high versus low turnover malignancies. Key differences in mechanism and cell cycle dependence. Drug, main mechanism, cell cycle specificity, target malignancy turnover. Cytarabine, Ara-C, DNA chain termination, DNA polymerase inhibition, S-phase specific, very short half-life in non-S phase, high turnover tumors, e.g. AML, ALL. Fludarabine, cladribine, inhibit DNA polymerase, ribonucleotide reductase, induce apoptosis, and affect non-dividing cells. Not strictly cell cycle specific, active in both dividing and resting cells. Low turnover tumors, e.g. CLL, HCL. Gemcitabine DNA incorporation plus potent ribonucleotide reductase inhibition, DNTP pool. Phase nonspecific, although S-phase preferred. Effective in solid tumors, even with slower proliferation. Detailed mechanistic comparison. 1. Cytarabine Ara-C, a cytidine analog that must be phosphorylated to Ara-CTP to become active. Primarily incorporates into DNA during S-phase, inhibiting DNA polymerase A and VTRAP, causing chain termination. Rapidly cleared from plasma, short intracellular half-life. Requires rapid cell division for efficacy, ineffective in indolent lymphomas or non-dividing cells. 2. Fludarabine and cladribine, purine analogs that inhibit DNA polymerase, inhibit ribonucleotide reductase, depletion of DNTPs, incorporate into DNA strand breaks, induce apoptosis via p53 pathways, even in non-dividing cells, effective in slow-dividing lymphocytes, including resting G-SAR phase B cells. This makes them ideal for CLL, HCL, and indolent lymphomas. Fludarabine and cladribine's ability to induce apoptosis in quiescent cells is the key reason they work in low-grade malignancies. 3. Gemcitabine, also a cytidine analog, but with two critical distinctions. Inhibits ribonucleotide reductase, global reduction in DNTP pool, starves DNA synthesis. Incorporates into DNA, causes mask chain termination, allows one more nucleotide addition, but then halts. Unlike cytarabine, gemcitabine is retained longer intracellularly, and its diphosphate-triphosphate forms persist. This makes it less strictly S-phase-specific than cytarabine. Hence, gemcitabine is effective even in tumors with lower proliferation indices, e.g. pancreatic, breast, and SCLC. Summary points. Cytarabine, strictly S-phase, rapid clearance, needs fast proliferation, acute leukemias. Fludarabine cladribine, apoptosis-inducing in non-dividing lymphocytes, CLL, HCL. Gemcitabine, long intracellular half-life, targets both DNA synthesis and nucleotide pools, broader phase activity, solid tumors.
Methotrexate can be used in the treatment of ectopic pregnancy if it is diagnosed early enough. What are the current recommendations for using methotrexate in ectopic pregnancy, and when it is appropriate to use methotrexate as the treatment of ectopic pregnancy? Also, can methotrexate be used to abort a normal pregnancy for medical reasons?
You're absolutely right. Methotrexate, MTX, is a well-established evidence-based treatment for early, unruptured ectopic pregnancy, and it has specific criteria and contraindications for safe and effective use. Here's a comprehensive, up-to-date overview based on ACOG, up-to-date, and high-quality medical literature. Methotrexate in ectopic pregnancy. Mechanism of action. MTX is a folic acid antagonist that inhibits dihydrofolate reductase, blocking DNA synthesis and cell replication, particularly in rapidly dividing trophoblastic cells. Indications for methotrexate in ectopic pregnancy. Methotrexate is appropriate when hemodynamic stability, no evidence of tubal rupture, reliable follow-up available, serial beta-HCG monitoring, patient is compliant and willing to avoid conception for a few months. Beta-HCG level, usually 5,000 millimiu milliliter for highest success rates, can be attempted up to 10,000 millimiu milliliter, less success. No fetal cardiac activity on transvaginal ultrasound. Size of ectopic mass 3.5 to 4 centimeters. Contraindications to methotrexate use. Absolute contraindications: hemodynamically unstable, evidence of tubal rupture or hemoperitoneum, breastfeeding, immunodeficiency, liver disease or transaminases 2 to 3 ULN, renal insufficiency, blood dyscrasias, anemia, thrombocytopenia, leukopenia, active pulmonary disease, peptic ulcer disease, intrauterine pregnancy, IUP, confirmed. Relative contraindications: high beta-HCG, 5,000 to 10,000, large ectopic size, presence of fetal cardiac activity. Methotrexate regimens. Regimen. Description. Monitoring. Single dose most common. MTX 50 milligrams per millisquare IM day 1. Measure beta-HCG on days 1, 4, and 7. Able 15% drop from day 4 to 7 equals success. If not, second dose may be given. 2 dose 50 milligram mercury IM on day 1 and day 4. Better success rate than single dose in select cases. Multi-die dose, MTX 1 mg mercury IM on days 1, 3, 5, 7. Leucovorin 0.1 mg on days 2, 4, 6, 8. Used in more advanced or high beta-HCG cases. More toxic success rates. Single dose MTX, 90% success when beta-HCG 5,000. Decreases with higher beta-HCG or ectopic size. Surgical treatment is considered if MTX fails or if rupture occurs. Can methotrexate be used to terminate a normal pregnancy? Yes, but only in very specific medical contexts. MTX is not routinely used for elective abortion. It can be used in medically indicated abortion under strict supervision, such as non-viable intrauterine pregnancies, e.g. early missed abortion, molar pregnancy, part of treatment regimen. Methotrexate plus misoprostol was once used in medical abortion, but mifepristone's misoprostol has largely replaced it due to greater safety and efficacy. Legal and ethical considerations. Use of MTX for abortion of a viable IUP is highly regulated and restricted in many countries. In the US, for example, MTX is not FDA approved for medical abortion of normal pregnancy, though it has been used off-label in some cases of fetal anomalies or life-threatening maternal disease. Key references. ACOG.
Which chemotherapeutic agents act by affecting the microtubule structures inside cancer cells?
Chemotherapeutic agents that target microtubules interfere with the mitotic spindle, which is essential for proper chromosome segregation during mitosis. These drugs are cell cycle specific, especially targeting the M phase, mitosis. They fall into two main classes. 1. Vinca alkaloids, microtubule polymerization inhibitors. Drugs. Examples: vincristine, vinblastine, vinorelbine. Mechanism: bind to beta-tubulin and inhibit polymerization of tubulin into microtubules. This prevents spindle formation and arrests cells in metaphase. Clinical uses: leukemias, lymphomas, solid tumors, e.g. neuroblastoma, testicular cancer. Toxicities: vincristine, neurotoxicity, peripheral neuropathy. Vinblastine, bone marrow suppression, vinblasts the marrow. 2 taxanes, microtubule depolymerization inhibitors. Drugs. Examples: paclitaxel, docetaxel, cabazitaxel. Breast. Mechanism: stabilize GDP-bound tubulin in the microtubule, preventing depolymerization. This freezes the mitotic spindle, preventing cell progression beyond metaphase. Clinical uses: breast, ovarian, lung, prostate cancers. Toxicities: neuropathy, myelosuppression, hypersensitivity reactions, SP with paclitaxel.
Okay, so we know that microtubules are important in neuronal function. So chemotherapeutic agents like vincristine and also taxanes, because they cause microtubule dysfunction, can cause peripheral neuropathy.
Yes, you're absolutely right. Microtubules play a critical role not only in mitosis, but also in neuronal function. Both vincristine, a vinca alkaloid, and taxanes, like paclitaxel and docetaxel, affect microtubules, and this impact can lead to neurotoxicity, which is a significant side effect of these chemotherapeutic agents. Here's why this happens. Microtubule function in neurons. Microtubules are a crucial component of the neuronal cytoskeleton, providing structure, support, and transport pathways for nutrients, organelles, and vesicles within the cell. In neurons, axonal transport relies on microtubules to move proteins and organelles from the cell body to the axon terminals, anterograde transport, and back to the cell body, retrograde transport. Clinical manifestation: motor and sensory neuropathies, numbness, tingling, pain, weakness, and it can even cause autonomic dysfunction. 2. Taxanes, paclitaxel, docetaxel. Mechanism: unlike vinca alkaloids, taxanes stabilize microtubules, preventing them from depolymerizing. Clinical manifestation: sensory and motor neuropathies. And similar to vincristine, this toxicity is also dose-dependent. Neurotoxicity mechanism and implications. Neurons are particularly sensitive to microtubule targeting agents because they are post-mitotic cells. They do not divide. Thus, any disruption to their intracellular transport system has significant consequences. Peripheral neuropathy, damage to nerves outside the brain and spinal cord, is the most common manifestation, but it can affect both sensory and motor nerves. Autonomic neuropathy can also occur with vincristine, affecting blood pressure regulation and gastrointestinal motility. Clinical management of neurotoxicity. Dose adjustment. Lowering the dose or delaying treatment can help manage toxicity. Neuroprotective agents. There's ongoing research into agents that can protect neurons from chemotherapy-induced damage, but none are currently standard practice. Symptom management. Anticonvulsants, antidepressants like duloxetine, and other agents may be used to manage neuropathic pain. Summary: both vincristine and taxanes target microtubules, leading to disrupted neuronal transport and neurotoxicity as a side effect, especially in peripheral nerves. The long-term use or high doses of these agents can cause dose-limiting neurotoxicities, such as peripheral neuropathy, which can significantly affect the patient's quality of life.
So let's talk about microtubules, which are a critical cytoskeletal component for axonal transport in neurons, and they provide a pathway for motor proteins such as kinesin and dynein, to carry organelles and other cellular products to and from the cell body and axon terminal.
Exactly. Microtubules are like tracks inside like kinesin and dynein, walk along these microtubules to transport cargo, like organelles or vesicles, between the cell body and the axon terminal. This system is super important for neuron function, especially for long neurons that need to move materials over long distances.
Okay, in neuronal microtubules, kinesin is involved in carrying the cargo forward, from the cell body to the nerve terminal, and dynein is involved in moving the cargo backward. So, what is the importance of microtubules in neurodegenerative? Hello?
Microtransportive diseases like Alzheimer's or Parkinson's, these structures are unstable. That disrupts the transport of essential protein to cell dysfunction and eventually cell death. So stabilizing microtubules is a key target in research for slowing.
Microtubules are formed by polymerization of tubulin dimers, contain an alpha tubulin and a beta.
Exactly. Those alpha tubulin and beta tubulin dimers stack together to form the micro. This dynamic assembly and disassembly process is essential for their function in maintaining cell shape and intracellular transport.
Almost all patients on vincristine chemotherapy develop some kind of peripheral neuropathy, which can affect sensory nerves, motor nerves, or autonomic nerves. So, approximately 20% of all invasive breast cancers overexpress HER2, which stands for human epidermal growth factor receptor 2.
Exactly. HER2 positive breast cancers tend to grow faster, but can also respond well to targeted therapies that focus on the HER2 protein. It's a key factor in determining the treatment approach. Would you like more details about HER2 positive treatments or any other aspect?
HER2 positivity not only can exist in breast cancers but also other solid tumors like stomach, lung, and ovary. The drug that is a monoclonal antibody and used to management of patients with HER2 positive breast cancer is trastuzumab.
Yes, that's right. Trastuzumab is a well-known monoclonal antibody used to treat HER2 positive breast cancer. It works by targeting the HER2 receptors on the surface of cancer cells, helping to slow their growth or even shrink them. It's also used in other HER2 positive cancers, like gastric cancer. Let me know if you'd like more info on how it works or other treatment options.
So because HER2 is an epidermal growth factor receptor, it is a tyrosine kinase receptor, and its downstream messengers include a MAP kinase pathway. When EGF attaches to the HER2 receptor, it upregulates the MAP kinase pathway and leads to tumor cell growth. What is the mechanism downstream of the receptor activator of nuclear factor kappa B? What is the mechanism of action of the receptor activator of nuclear factor kappa B? Hello?
Hi there. How's it going?
What is the mechanism of action of nuclear factor kappa B?
Nuclear factor kappa B, or NF-kappa B, is a protein complex that acts as a transcription factor. Its main role is to regulate the expression of genes involved in inflammation, immune response, cell survival, and proliferation. When a cell is exposed to signals like stress, cytokines, or infections, NF-kappa B is activated. Normally, it's bound in the cytoplasm by an inhibitor called I-kappa B. When activated, a signaling cascade leads to the degradation of this inhibitor. That frees NF-kappa B to move into the nucleus where it binds to DNA and promotes the transcription of target genes. In short, NF-kappa B controls how cells respond to inflammation and stress.
So the receptor activator of nuclear factor kappa B, or RANK, which type of receptor is that?
RANK, or the receptor activator of nuclear factor kappa B, is a type of receptor that belongs to the tumor necrosis factor, or TNF receptor family. This receptor plays a crucial role in bone metabolism and the immune system. RANK is found on the surface of certain cells, like osteoclast precursors in bone. When it binds to its ligand called RANKL, it triggers signaling cascades that promote the formation and activity of osteoclasts, which are responsible for breaking down bone tissue. This signaling is also linked to the activation of NF-kappa B, which regulates genes involved in inflammation and immune response. So, in short, RANK is a TNF family receptor that's important for bone remodeling and immune responses.
So downstream the RANK receptor itself, what are the secondary messengers inside the cell for the TNF receptor family?
For TNF receptor family members like RANK, the key intracellular messengers involved are specific adapter proteins and kinases. When RANK is activated by RANKL, it recruits adapter proteins like TRAF6, which stands for TNF receptor-associated factor 6. TRAF6 is a crucial adapter that links the receptor to downstream signaling pathways. From there, TRAF6 activates several key signaling cascades, especially the NF-kappa B pathway and the MAP kinase pathway. These pathways involve other signaling molecules, like IKK complex proteins for NF-kappa B activation, and kinases like JNK or ERK for MAP kinase signaling. In summary, the main secondary messengers for TNF receptor family signaling are adapter proteins like TRAF6, and the downstream kinases and transcription factors they activate, especially NF-kappa B and MAP kinase pathways.
Are the TNF family receptors tyrosine kinase receptors, or are they of the JAK-STAT family of receptors? Hello?
Hi, I can hear you. Let me answer that question. TNF family receptors are not tyrosine kinase receptors, nor are they part of the JAK-STAT receptor family. Instead, TNF receptors are a distinct family of receptors that typically lack intrinsic enzymatic activity. They rely on adapter proteins like TRAFs to transmit signals inside the cell. So TNF receptors function differently from tyrosine kinases or JAK-STAT receptors.
But most other cytokines are of the JAK-STAT family of receptors. Is that correct?
Many cytokine receptors do use the JAK-STAT pathway, but not all. The JAK-STAT pathway is commonly associated with receptors for interleukins, interferons, and some growth factors. However, there are many other cytokine receptors that use different signaling pathways. For example, TNF receptors, like we discussed, use TRAF proteins and the NF-kappa B pathway instead of JAK-STAT. So you're right that a large portion of cytokines, especially those involved in hematopoiesis and immunity, signal through JAK-STAT. But there are other families of cytokine receptors with different downstream signaling mechanisms.
So, like trastuzumab, which is a monoclonal antibody against the HER2 receptor, we have denosumab against the RANK receptor. Also, there is bevacizumab, which is a monoclonal antibody against the VEGF receptor, which is another tyrosine kinase receptor. Could you name some of the monoclonal antibodies that are used in cancer treatment and their respective receptors and their mechanism of action?
Let me give you a few well-known examples of monoclonal antibodies used in cancer therapy, along with their targets and mechanisms. First, trastuzumab targets the HER2 receptor, a tyrosine kinase receptor involved in cell growth. By blocking HER2, it inhibits signaling and slows tumor growth in HER2-positive breast cancers. Second, rituximab targets CD20, a protein on the surface of B cells. It's used in certain lymphomas and leukemias. By binding to CD20, it helps the immune system destroy these cancerous B cells. Third, bevacizumab blocks VEGF, not the receptor itself but the vascular endothelial growth factor. By doing this, it reduces the growth of blood vessels that feed tumors, helping to starve the cancer. Finally, denosumab, which you mentioned, targets rankle, and it's often used to prevent bone complications in cancers that have spread to the bones. Each of these monoclonal antibodies interferes with a specific receptor or signal, stopping tumor growth or killing cancer cells directly.
In hormone receptor positive breast cancer patients that have an overexpression of estrogen receptors or progesterone receptors, they are treated with anti-estrogen medications to reduce tumor cell proliferation. Why tamoxifen is used in premenopausal women while aromatase inhibitors such as anastrozole, letrozole is used in postmenopausal women?
That's a great question. The key difference lies in how estrogen is produced before and after menopause. In premenopausal women, the ovaries are the primary source of estrogen, and it's produced in large amounts. Tamoxifen works by blocking estrogen receptors directly on tumor cells. It essentially prevents estrogen from binding to those receptors, slowing the tumor growth. This approach works well even when the ovaries are still producing high levels of estrogen. In postmenopausal women, however, the ovaries stop producing significant amounts of estrogen. Instead, small amounts are produced by converting androgens into estrogen using an enzyme called aromatase. Aromatase inhibitors like anastrozole or letrozole block this enzyme, reducing the overall estrogen levels in the body. That's why aromatase inhibitors are more effective in postmenopausal women, where estrogen production is minimal and mostly depends on aromatase activity.
In hormone receptor positive breast cancer, the choice between aromatase inhibitors, AIs, and tamoxifen depends significantly on the patient's menopausal status because of the differences in estrogen production before and after menopause. Overview of estrogen sources. Status: major estrogen source, estrogen type. Premenopausal, ovarian secretion, gonadotropin dependent, estradiol E2. Postmenopausal, peripheral conversion of androgens via aromatase in adipose, muscle, etc. Estrone E1 converted to E2. Why aromatase inhibitors are effective only in postmenopausal women. Aromatase inhibitors, e.g. letrozole, anastrozole, exemestane, block the conversion of androgens to estrogens in peripheral tissues by inhibiting the aromatase enzyme. In postmenopausal women, the ovaries are inactive, and almost all estrogen comes from aromatase-mediated conversion in peripheral tissues. Blocking aromatase in postmenopausal women dramatically reduces estrogen levels, effectively starving hormone receptor-positive tumors of estrogen stimulus. In premenopausal women, AIs block peripheral estrogen synthesis, but the ovaries compensate by increasing estrogen production due to loss of negative feedback, increased LH-FSH from pituitary, which negates the effect of the aromatase inhibitor unless ovarian function is concurrently suppressed, e.g. via GnRH agonists or oophorectomy. Why tamoxifen is useful in both, but especially in premenopausal women. Tamoxifen is a selective estrogen receptor modulator, SERM. It blocks estrogen receptors in the breast, but has partial agonist effects in bone and endometrium. In premenopausal women, it is highly effective because it does not interfere with ovarian estrogen production, but still blocks estrogen's proliferative effects in breast tissue. It's safe to use alone without needing to suppress ovarian function. In postmenopausal women, tamoxifen is also effective, but aromatase inhibitors are superior in terms of disease-free survival and recurrence prevention based on major trials like ATAC, Big 198, and others.
We know that cancer cells undergo genetic mutations that drive oncogenesis, But these genetic mutations can also create cancer neoantigens, which are unique proteins that are not found in healthy cells.
Yes, cancer cells often develop genetic mutations that lead to the production of neoantigens, novel proteins or altered versions of normal proteins not present in healthy cells. Immunotherapy, especially checkpoint inhibitors, takes advantage of these neoantigens by enhancing the immune system's ability to target and destroy cancer.
So these not self proteins are recognized by patrolling cytotoxic T cells, and they destroy these cells.
When the T cells identify these not self proteins on the surface of cancer cells, they become activated and destroy the tumor cells. This process is enhanced in immunotherapy, particularly with checkpoint inhibitors, which block inhibitory signals that normally prevent T cells from attacking. This allows for a more effective immune response, targeting the cancer cells.
Which types of cancer cells are more prone to this type of immune therapy?
Cancers with a high mutation burden, i.e., those with many genetic mutations, tend to produce more neoantigens, making them more likely to respond to it.
What causes cancers to have many mutations?
Head and neck squamous cell carcinoma, frequently associated with high mutation loads. Bladder cancer and colorectal cancer, especially those with microsatellite instability, MSIH, are also responsive. These cancers have a greater likelihood of benefiting from checkpoint inhibitors like pembrolizumab or nivolumab.
So cancers with defects in mismatch repair proteins and high microsatellite instability are more susceptible to immune recognition because these types of cancers rapidly accumulate mutations.
Cancers with defects in mismatch repair, MMR proteins, and high microsatellite instability, MSIH, accumulate mutations at a much higher rate, leading to the generation of more neoantigens. These mutations make the cancer cells more recognizable to the immune system, particularly cytotoxic.
What causes the microsatellite instability in the first place?
Microsatellite instability, MSI, occurs due to defects in the mismatch repair MMR system. The MMR system is responsible for repairing errors that arise during DNA replication, particularly those involving short repetitive DNA sequences called microsatellites. When this repair system is impaired, errors in these sequences accumulate, leading to microsatellite instability. These mutations can be inherited, as in Lynch syndrome, hereditary non-polyposis colorectal cancer, HNPCC, or acquired in sporadic cancers. The lack of proper DNA repair results in the accumulation of mutations across the genome, increasing the likelihood of producing neoantigens, which makes these cancers more susceptible to immune attack via immunotherapy.
So what strategies do cancer cells have to thwart the cytotoxic actions of T cells?
Sorry, I'm having issues right now. Could not understand what you...
So I will repeat again.
Sure, go ahead.
What strategies do cancer cells have to thwart the cytotoxic T cell detection?
Without MHC class 1, T cells can't recognize the cancer cells. 2. Checkpoint proteins. Cancer cells often express checkpoint proteins like PDL1 or CTLA4, which bind to PD1 or CTLA4 receptors on T cells, suppressing their activation and preventing them from attacking the tumor. 3. Immunosuppressive microenvironment. Tumors often create a local environment rich in immunosuppressive cells, like regulatory T cells and myeloid-derived suppressor cells, and cytokines, e.g. TGF-beta, which inhibit T cell function. 4. Antigen loss. Cancer cells can sometimes lose or mutate the neoantigen or the gene encoding it, reducing their recognition by T cells. These mechanisms allow cancer cells to avoid immune detection. But immunotherapies, like checkpoint inhibitors, can block some of these evasion strategies, restoring the immune system's ability to target cancers.
So what is the function of PD1 and CTLA4?
PD1, programmed death 1, and CTLA4, cytotoxic T lymphocyte antigen 4, are immune checkpoint proteins that play crucial roles in regulating T cell activity to prevent excessive immune responses and autoimmunity. 1. PD1. PD1 is expressed on activated T cells, and when it binds to its ligands PDL1 or PDL2, Often expressed on tumor cells, it sends an inhibitory signal that reduces T cell activation and function. This helps to prevent immune overactivity, but can also allow cancer cells to escape immune surveillance by expressing PD-L1, which blocks T cell responses. 2. CTLA-4. CTLA-4 is also expressed on activated T cells and acts as a negative regulator by competing with CD28 for binding to B7 molecule 86 on antigen. When CTLA-4 binds B7, it inhibits T cell activation, essentially providing a brake to the immune response, preventing overactivation. Both proteins are targeted by checkpoint inhibitors like pembrolizumab for PD-1 and ipilimumab for CTLA-4 in cancer therapy to enhance T cell activity. T regulatory cells, TREGs, suppress immune responses through several key mechanisms, particularly in the context of cancer. These mechanisms allow TREGs to maintain immune tolerance and inhibit the activity of immune cells that could attack. The main mechanisms by which TREGs suppress immune reactions include 1. Secretion of immunosuppressive cytokines, TGF-beta, transforming growth factor beta, and IL-10, interleukin 10, are the primary cytokines produced by TREGs. These cytokines create an immunosuppressive environment by inhibiting the activation and function of cytotoxic T cells, helper T cells, and dendritic cells, which are essential for an effective anti-tumor response. 2. Cell-cell contact-dependent suppression. TREGs can directly suppress other immune cells through cell-to-cell interactions, particularly by binding to CD80, CD86 on antigen-presenting cells, APCs, via CTLA-4, a key inhibitory receptor on TREGs. This interaction prevents costimulatory signals necessary for T cell activation. 3. Metabolic disruption. TREGs can modulate the metabolic environment of the tumor microenvironment by consuming IL-2, which is essential for the proliferation of other immune cells. By depriving other immune cells of IL-2, TREGs limit their growth and activation. TREGs can also release adenosine via CD39 and CD73, which promotes an immunosuppressive environment by inhibiting effector T cell function. 4. Induction of apoptosis in effector T cells. TREGs can induce apoptosis, programmed cell death in effector T cells through the expression of FASL, Fas ligand, on their surface, which binds to Fas on target immune cells. 5. Induction of tolerogenic dendritic cells. TREGs influence dendritic cells, DCs, to become tolerogenic rather than immunogenic. These tolerogenic DCs promote immune tolerance by presenting antigens in a way that does not activate T cells or by inducing the differentiation of more TREGs. 6. Regulation of the tumor microenvironment. TREGs often accumulate in tumors and help create an immunosuppressive microenvironment that supports tumor growth and metastasis. They do this by promoting angiogenesis, blood vessel formation, and limiting the effectiveness of anti-tumor immunity. Together, these mechanisms allow TREGs to suppress the immune system's ability to target and destroy cancer cells, making them a significant barrier to cancer immunotherapy. In many cases, targeting TREGs or blocking their activity is being explored as a strategy to enhance anti-cancer immune responses. Immune checkpoint inhibitors, such as PD-1, PD-L1 inhibitors, e.g. pembrolizumab, nivolumab, and CTLA-4 inhibitors, e.g. ipilimumab, have revolutionized cancer treatment, but they can cause a range of immune-related adverse events due to the activation of the immune system. These adverse reactions occur because, while enhancing immune responses against cancer, the immune system may also target normal tissues.